Postoperative pain assessment and management. The objectives of this presentation are to discuss current evidence-based practice on postoperative pain assessment and management, to provide a situational analysis on postoperative pain assessment and management, to identify any existing or potential challenges of implementing the research findings into practice, and to suggest possible solutions. Postoperative patients require pain assessment and management as part of their vital care following surgery. Although there has been a number of new developments of techniques to manage pain, many patients continue to be afflicted postoperatively. Pain is a complicated event and it must be recognized prior to any investigating. It comprises physiological, emotional, cognitive, and social dimensions. Research on postoperative pain assessment and management is quite significant. However, the delivery of assessing and managing pain remains inadequate. Each patient has a right to pain relief, whether it is postoperatively or in general. There are numerous barriers to assessing and managing postoperative pain which have not yet been overcome. Various studies and literature reviews were carried out to establish these barriers. According to the literature review carried out by Bell and Duffy in 2009, findings suggested that some of the main barriers to effective pain relief include time management, interruptions whilst carrying out pain assessment and management, beliefs and attitudes towards pain assessment, and interpretation of pain. Time management and interruptions whilst carrying out assessment and management. As quoted by Bill and Duffy in 2009, postoperative pain assessment should be frequent and simple. Nurses are in the most favorable position to assess and manage pain as they devote the most time with the patient of all the health professionals. In 2002, Manius carried out a study which suggested interruptions whilst delivering pain assessment and management allowed nurses to get distracted and consume time on other things. This played a vital role in managing the patient's pain efficiently. Manius in 2005 interpreted these results and explored verifications that pain assessment was reactive and not preemptive. Disappointingly, the findings noted that the strategies followed by nurses in pain decision making didn't show adequate management and no proper time was given to use the proper pain assessment tools. Furthermore, studies showed that there was a significant delay between the request of analgesia for pain management and analgesia delivery. Nurses were unable to deliver the immediate analgesic and comfort requirements of patients. In an experimental study using a survey and interviews of nurses in UK hospital wards, Shafaro explored that time insufficiency, staff shortages, and expanded workload brought up by 39.3% of participants were outstanding elements contributing to inadequate pain guidance in practice. Manius in 2002 agreed with the findings of Shafaro where they come to an end that nurses have underlying barriers to sufficient pain relief. Dealing with telephone calls was a capital source of interruption. Findings showed that this kind of interruption will stop nurses from offering effective verbal, nonverbal, and behavioral manifestations of pain. On the other hand, observed nurses tend to carry on conversations and meetings with other nurses and health professionals. Although the conversations held might be discussing patients' medical history, medications, and clinical actions. However, these interruptions can occupy a major portion of the nurse's daily observations, influencing remarkably on their 24-hour availability and existing inpatient area and on pain management and assessment procedures. Beliefs and attitudes towards pain assessment and management. Sloman in 2005 declared that cultural beliefs and behavioral attitudes affect the interpretation of pain and influence post-operative pain management and assessment. Moreover, Bedard in 2006 suggested that following the application of evidence-based drug and pain management tools, pain intensity decreased, but patients' cultural beliefs increased and fear and anxiety regarding side effects and addiction. Furthermore, qualitative studies showed that it is difficult to put own judgments aside and agree with others' beliefs and attitudes. Findings showed that nurses struggled to practice their attitudes and listen to what the patient had to say, thus affecting their management and practice and decision making. Interpretation of pain. Misleading and inadequate interpretation of postoperative pain may cause clinical and psychological modifications that may enlarge the probability rates of morbidity and mortality in addition to the cost of treatment, thus reducing the quality of survival postoperatively. It may be linked with deep vein thrombosis, pulmonary embolism, pneumonia, delayed injury healing, and loss of confidence. In an experimental study by McLennan in 2004, regardless of the 3-hourly pain measurement assessment, supported by the execution of an educational nursing program, pain scored enhanced by only 7.3%. The researcher put forward that the theory-practice gap is the existing challenge in relation to assessment of postoperative pain. Findings suggested that postoperatively nurses focused on incisional pain rather than any other causes of pain and discomfort. Changes to clinical practice and possible solutions. Inadequately, relief postoperative pain is a prime load for healthcare services. It holds up healing and rehabilitation, delays discharge from hospitals, and is a chief cause of patient dissatisfaction. Nevertheless, a number of studies have demonstrated converting theoretical knowledge into clinical practice in postoperative pain management often fails to achieve the desired goals. The complications and challenges may be multifactorial. However, a vigorous and joint multidisciplinary attempt towards an ordinary goal of enhancing pain assessment and management in practice is needed to remedy the cavity between theory and practice. Involving and educating patients to optimize treatment. Another potential challenge was involving patient in decision making to achieve the optimized health outcomes. Implementing such research findings into practice required full understanding of the patient centered care concept and importance of patient satisfaction. Clinical practices methodology has developed approaches with key attributes that consider shared decision making. Studies have showed that giving patients the chance to involve in decisions is strongly linked with less decisional conflicts and better rates of patient satisfaction. Patients must have the right to be well informed about all the clinical options and measures to be considered. However, patients require current and relevant organized systematic information and face-to-face education in regards to treatment, risks, and benefits of any given action. Professional nursing education and training. Nurses often have the most persistent exposure to patients' health and needs, but alterations in their understanding of postoperative pain management, attitudes, and point of views are needed before optimal pain management can be offered. Studies have highlighted a high rate of nurses in wards who assume and overestimate the chances of addiction in postoperative patients. Only 25% of nurses in one of the surgical ward surveys estimated correctly the risk of opioid analgesic addiction. This lack of training and knowledge has a vital effect on nurses and their clinical judgments when they administer opioids with lower doses than prescribed, as they are in fear of any respiratory depression. As they are the chief body responsible for patients' observations, nurses would very much benefit from improving and sustaining competence in these areas, as well as in converting theory into productive practice and postoperative pain management. Supportive and educational programs are required to help nurses implement their duties and counteract attitudes addressed in the 2005 clinical experiment by Manias. The following diagram highlights the importance of knowledge-based continuing education for nurses to learn the professional behaviors and attitudes and earn the current evidence-based skill. This approach is mandatory to sustain and advance their understanding of concerns such as analgesic regimens and set of reasons underlying their use, latest management techniques, and the outcomes of poor pain control. To conclude, all patients with postoperative acute pain have the right to acquire adequate pain management and assessment. It is really important as nurses to focus on patient-centered care with involvement of shared decisions, supported with better educational programs for both nurses and patients. This can be implemented by accepting all organizational changes and agreed protocols to help optimize treatment options, increase satisfaction, and decrease postoperative pain complications.